You walk into your first patient's room and you realize it's a child with ankle pain and it's really swollen and it hurts, and you wonder, do they have a growth plate injury?
And then you receive an EMS box call for a patient who had several seizures, but they continue after EMS has already given some benzodiazepines. And you wonder what should be the next medication you reach for.
In this episode of Critical Decisions in Emergency Medicine, we will talk about pediatric growth plate fractures, how to recognize them and manage them.
We will also address management of seizures in the ED, including first-time seizures and status epilepticus.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices in Florida.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the February 2025 episode of Critical Decisions in Emergency Medicine podcast. Each month, we discuss 2 lessons that are bread and butter emergency medicine or things that are cutting edge.
In addition to the 2 lessons, there are also a lot of other features, such as the Critical ECG, the Critical Procedure, and as our listeners know, my favorite, the LLSA Literature Review.
For our first lesson, we have Race Against Time, Seizure Presentations. Thank you to Drs. Andrew Piner and you, Dr. Wendy Chang, for writing this article. I really like how this reminds us that there's a range of presentations from first-time seizures to status epilepticus. And those can be really, really different. Let's start with some definitions so we're all on the same page on what we're talking about.
That's right. I think whenever we refer to literature, they often talk about provoked or not provoked seizures. And generally, when we talked about a provoked seizure, it's one that occurs within 7 days from some sort of an inciting factor, whether it's trauma, stroke, or some metabolic abnormality. Now, if a patient has a remote history of a brain injury without an acute illness and then comes in with a seizure, that's considered unprovoked. Most seizures, thankfully, self-terminate, but if there is ongoing seizure activity for more than 5 minutes or recurrent seizures without return to baseline, then we're talking about status epilepticus.
Got it. So let's start with first-time seizures. How do we evaluate patients coming in with that presentation?
This is something we're really familiar with, and certainly it all starts with a good history and physical. And in addition, you may get some diagnostic tests like a finger stick, ACG, and ECG. Chemistries, LFTs, and blood alcohol levels can be helpful in certain situations. And often we're also talking about brain imaging, probably a CT, since that is more widely available. Ultimately, though, these patients would benefit from an MRI, and an EEG can also help predict whether or not they are at risk for short-term seizure recurrence.
Got it. Pretty straightforward. So how do we actually identify these patients who are going to be high risk for seizure recurrence? Because I'm assuming we're going to need to do things a little differently there.
That's right. We generally think about people who have structural brain abnormalities, whether, again, a prior TBI or stroke, if they're presenting with nocturnal seizures, and then if they're in alcohol withdrawal, since we've all seen those patients definitely have recurrent seizures. Generally, if a patient were to have a hyperacute recurrence, that would generally happen within a few hours of presentation. And specifically in alcohol withdrawal, more than 85% of seizures actually recur within 6 hours. So these patients with higher risk of seizure recurrence should really be considered for treatment with some sort of an anti-epileptic medication.
Makes sense. All right, so let's talk about status epilepticus. Just like you shared with us, those are the ones that are going to continue to seize. What is your approach for treating these patients?
Yeah, so these patients, since they may be having ongoing convulsive seizure activity, we're really talking about giving medication to abort the seizure to try and reduce that brain injury. There's an algorithm that we included in the article that you can refer to that gives a little bit of a timeline that you can consider. Generally, we're thinking about trying to give some sort of an emergent treatment within the first 5 minutes and then urgent treatments within 30 minutes. And the emergent treatments would then include, of course, our standard ABCs, getting your finger stick, administering that first-line therapy, which is benzodiazepines to abort the seizures. Now, if the patient continues to seize, then we're trying additional seizure medications like second-line therapies, as well as think about if there's other causes, if there are seizures that we need to target our treatment for, such as hyponatremic patients, maybe they need hypertonic saline. or magnesium for eclampsia.
Makes sense. So let's talk about benzos. How much should we give to abort seizures? Because there's a lot of people who are worried about respiratory depression if you give too much, right?
Yeah, that's definitely a myth because while yes, benzodiazepines can theoretically depress the respiratory drive in patients, in the seizing patient, there's actually more risk from the ineffective ventilation from their convulsive activity. And it's actually been shown in the literature that giving benzos to abort the seizures actually does not increase incidence of needing some sort of airway ventilation support. And so, in terms of how much benzos to give, it really depends on how you're giving it and which benzo. If you don't have IV access, you want to give midazolam 0.2 milligrams per kilogram IM. If you do have IV access, then you can give lorazepam 0.1 milligrams per kilogram IV. Don't forget that you can always get an IO for access if you don't have IV access. And it's been found again and again in literature. Unfortunately, we continue to underdose benzodiazepines, even with all the studies that says that we do so.
Definitely a great reminder of the safety of benzos and its importance. So let's just say benzos don't work. What about second-line therapies?
Well, if your patient is still seizing after giving that appropriate dose of benzodiazepine, then you can repeat the dose, but you should also start preparing for second line therapy. And from the ESET trial, we learned that levetiracetam, valproate, and fosphenytoin all have similar efficacy. So choose your pick. It is important, though, the dose of these medications also should be appropriately given, and that would be 60 milligrams per kilogram for levetiracetam, 40 milligrams per kilogram for valproate, and 20 milligrams per kilogram for fosphenytoin.
Great reminder of the correct dosages. Definitely not the 1 gram of levetiracetam for everybody because people do not weigh 30 kilos.
That's right.
Okay, so what if the patient continues to seize even after we've given an appropriately dosed benzo? We repeated it, we gave that second line therapy, and you made sure that is the correct dose. Now what?
Wow, so now we're really in that refractory status epilepticus territory, and we want to continue to escalate our treatment, even using anesthetic agents. And so that does mean, of course, intubating a patient and starting them on some sort of anesthetic agent. When intubating a patient, you can choose an induction agent that also have anti-seizure properties. So that might be propofol, midazolam, or even ketamine, because ketamine can target NMDA receptors, which is an alternative mechanism in seizure propagation. Now, the other thing to remember after you intubate and put them on this sedation to control their seizure is that you also need to obtain EEG to know if you're actually achieving seizure control electrographically.
Makes sense. So let's go back to what you discussed earlier about disease-specific treatment of seizures. What specific scenarios are you talking about?
So I mentioned a few, but there are a few others to consider. Really, we're talking about precipitating factors to why the patient is seizing and treating that underlying condition. So, of course, there's hypoglycemia, that's easy to treat. Severe hyponatremia, those patients certainly can present with seizures, and we may need hypertonic saline. Also, other conditions like hypertensive encephalopathy, eclampsia, and PRESS. These are really a spectrum of conditions, all shared by elevated blood pressure and neurologic symptoms. In eclampsia, we know that magnesium is a treatment, and it actually has been shown to terminate seizures better than benzodiazepines and phenytoin. And we always learn about in boards, and possibly people have seen in isolated cases, are refractory seizures from pyridoxine or B6 deficiency, classically with INH toxicity. But it's also been described in chronic alcohol use. And so in this particular case, you would want to give pyridoxine as a 1 gram to 1 gram equivalent dose, or just simply 5 grams empirically.
Got it. Great reminders. Thank you. Well, thank you again, Wendy, for writing this article and for going through it with me today. I've learned a lot about a pretty high risk presentation, which are patients with seizures. It's a great reminder that with first time seizures, we definitely need to get a finger stick, pregnancy test, and ECG and chemistry for all of our patients. And then the other things like CT and EEG, those are things that can be done later to understand the risk of seizure recurrence and other underlying abnormalities depending on the clinical scenario. That the high-risk patients are the ones with structural brain abnormality, alcohol withdrawal, nocturnal seizures, and then if we have the information available, the EEG abnormality. And that might affect our need to discharge people with medications or even keep them in the hospital. For status epilepticus, this was a great reminder of the definition that it's ongoing seizure activity for more than 5 minutes and that we should not be waiting around for longer than that to treat patients. That benzos should be given, they should be appropriately dosed. Respiratory depression is not a fear in this case because if we don't treat them, it's actually worse for that. The correct dosage is midazolam 0.2 per kilo with a max of 10. Lorazepam, if we have IV access, is 0.1 per kilo for a max of 4. And then we repeat that. If that still doesn't work, we do the second-line therapies, and that's your levetiracetam, 60 per kilo, valproate, 40 per kilo, and phospheny, 20 per kilo. And these need to be the correct dosages because otherwise we're just underdosing people and then wondering why it does not work. If still, after all this, it doesn't work, that's when patients need to be intubated and placed on IV anesthesia. Whether we're talking propofol, midazolam, ketamine, a combo, it really depends on the situation. At that point, obviously, we're talking about very sick individuals who are going to the ICU and need an EEG for us to make sure that we're getting that electrographic seizure control. Obviously, we need to make sure that there's no other underlying causes that need to be fixed, like hypoglycemia, severe hyponatremia, eclampsia, and so on, or overdoses. And for those patients, we need to give them the specific treatment for that condition.
That's right. Thank you, Danya, for the summary.
For our critical ECG this month, a patient is coming in with weakness and a syncope. And if you look at the EKG, I don't know about you, Wendy, but it gave me palpitations because I can see a second-degree AV block that's pretty high grade with a wide QRS. And of all the second-degree AV blocks, that is not the one you want to have because that's the highest risk. Again, the wide QRS and the high grade. When we say high grade, that means that there's multiple non-conducted beats. So as a reminder, with second-degree AV blocks, some of the P waves are not conducted. For type 1, which is not what we have here, you have the progressive PR lengthening and then the beat drops. Type 2, which is what we have here, is that you have a fixed PR interval and then you have a sudden dropped beat. So the PP interval is consistent. And in this particular one, the QRS is wide, which again makes it higher risk. A picture is worth 1,000 words. Take a look at the EKG and remember that if you see that, run towards the phone to get your cardiologist involved because those are very sick patients that are at high risk of deteriorating. For our LLSA Literature review, we're reviewing an article by Bridwell et al. That was published in the Journal of Emergency Medicine in 2022, entitled Balloon Tamponade for the Management of Gastrointestinal Bleeding.
Now, we generally think about balloon tamponade in upper GI bleeding, specifically variceal bleedings, because of the high mortality associated with that. And it's really effective in helping us achieve hemostasis, but it really should be as a bridge to definitive management, such as band ligation, sclerotherapy, or TIPS. And it should not be used in all comers with upper GI bleeding, really only hemodynamically unstable bleeds where there's going to be some sort of delay to their endoscopy and such. The contraindications are patients who are not intubated because they need a secured airway for this, those who have esophageal strictures, or some sort of prior esophageal gastric surgeries that make them high risk for certainly perforation complications from displacement. Now, we may remember that there are 3 different types of balloon tamponade devices. The Linton necklace is a single gastric balloon, whereas the Sinstakin Blakemore and the Minnesota have 2 balloons, both a gastric as well as an esophageal balloon. And to place these, as we also remember, we want the patient generally upright because you're having an upper GI bleeding and probably an airway compromise. And after you secure the airway, you want to measure the tube from the bridge of the nose to their xiphoid, and then lubricate the balloon and insert it orally into the esophagus. Probably using McGill forceps will be helpful because it's going to be slippery and you want to direct it correctly. But we want to also make sure we don't damage the balloon. Now, the next steps are that you want to actually attach a manometer or syringe to the gastric balloon port and only inflate it with about 50 cc's of air, followed by a chest x-ray, because you want to confirm that you actually have the gastric balloon in the stomach before you then fully inflate it, because we don't want to, of course, have an esophageal placement and overextend and cause esophageal injury. Once that is fully inflated in the stomach, you want to secure the tube. And this is where we all heard of various techniques, but the technique shared here is using a rolled cloth that we often have in the ED. You want to tie one end of it to the external end of the device and the other end to a bag of IV fluids to use it as traction, essentially by hanging that over an IV pole. Now, if you still do not have hemostasis with inflation of the gastric balloon, then if you happen to have the two types of tubes that also have an esophageal balloon, you can inflate that. And you'd want to inflate it about 30 to 40 millimeters mercury with another x-ray to confirm placement of the esophageal balloon. If the patient ends up in your care for more than 24 hours, that's a lot to handle, but you would then want to deflate the esophageal balloon every 6 hours just for a few minutes to limit the amount of mucosal injury, ischemia, and such.
Got it. Well, thank you for reviewing this. Definitely not the case that you want to see when you walk into the emergency department, but one that you want to know how to manage on these very rare occasions. So switching gears to ortho, our critical cases in orthopedics and trauma is a case of a 20-year-old college football lineman presenting with wrist pain.
So he happened to have a prior wrist injury about a year ago, but unfortunately didn't really follow the instructions for bracing and try to play through his injury. And so on this presentation, he has snuff back tenderness. He's not able to really flex his wrist past midline, and the x-ray shows a non-union of his scaphoid fracture.
Yikes. So scaphoid fractures account for 60 to 90% of carpal fractures. The poor vascular supply leads to challenges with healing. And that's why we always talk about empiric immobilization and a thumb spike, a splint, or cast for initial management in the emergency department, even when we suspect it, not even confirm it. And non-adherence with immobilization leads to fracture displacement and non-union, which can lead to degeneration with decreased range of motion and functional impairment. These patients need to be treated with open reduction internal fixation to prevent this after non-union occurs. Moving on to a different topic, our critical procedure this month is for suprapubic aspiration. It's a pretty uncommon procedure, but sometimes necessary to obtain a urine sample, such as in cases of phimosis, adhesions, or strictures, and we can definitely use a point-of-care ultrasound for added safety.
I think the procedure is pretty self-explanatory, but just a few tips. If you're dealing with a young child, having them in a frog-leg position will help you get into the area that you're working with. And in other cases where you may have difficult anatomy, you may just want to consider direct placement of a suprapubic catheter rather just aspiration itself so that it can facilitate ongoing care.
Makes sense. And staying with the whole urine theme, but hopefully not in the same patient, our critical image this month is of a 64-year-old homeless man with Crohn's disease and COPD who's presenting with abdominal pain. He's had recent ED visits, multiple of them, for UTIs treated with antibiotics. He is cachectic, he has diffuse abdominal tenderness. So you get a CT, and then you realize that he has an enhancing fluid structure, cephalad to the bladder, concerning for a colovesical fistula.
I don't think I saw this coming based on the case presentation, so a good reminder. 70% of colovesicular fistulas are related to diverticular disease. There are other causes that we have to consider too, including trauma, radiation therapy, iatrogenic injuries. And in the case of this particular patient, they also have other risk factors such as the Crohn's disease and poor nutritional status. Now, normally you would want to get a CT pelvis with IV contrast to better visualize the fistula tract. Other clues that you may look for on your CT are air in the bladder, inflammatory changes of the bladder wall or the adjacent bowel. For this particular patient, unfortunately, antibiotics is not adequate to treat the UTI and the colonization, and he would actually need surgery.
Well, switching gears to pediatrics, this is a case of a 4-year-old with sickle cell disease with intermittent hip pain and fever. The child was seen at another hospital where an x-ray was done, the white blood cell count was done, it was normal, but they had elevated inflammatory markers and they were told to follow up with a pediatrician. On your exam, the child has difficulty with ambulation and left hip pain without overt swelling, erythema, or fluid collection. You obtain an MRI, and that shows a left abdominal adductor muscle myositis and multifocal osteomyelitis.
Wow, I did not see that coming. It's a good reminder that we have a differential to consider for any child that's presenting with limping symptoms, and that's really dependent on whether or not they have a fever. In febrile patients, we need to consider septic arthritis, transient synovitis, pyomyositis, as well as osteomyelitis. Now, in afebrile patients, we're generally thinking about trauma, slipped capital femoral epiphysis or SCIFI, like calf-Perthes disease, avascular necrosis, as well as potentially some benign bone tumors.
Pediatric osteomyelitis is commonly caused by Staph aureus in community-acquired infections. Kingella kingi is associated with upper respiratory infections, and then we also have strep pyogenes and strep pneumonia. Gram-negative bacteria can be involved in penetrating trauma. In neonates, we got to also think of E. coli and group B strep. And unfortunately, there's no standard diagnostic criteria that can help us make this difficult diagnosis.
Often we do get an x-ray to rule out fractures or other bone pathologies. Now, as with this case, oftentimes we end up having to get an MRI because it's most sensitive and specific. If you are suspecting multifocal osteomyelitis, you can also consider getting a whole body PET CT to really scan for the multiple locations. Now, there is a separate entity that's called recurrent multifocal osteomyelitis, and it's actually an autoinflammatory process rather than infectious, and it causes recurrent bone inflammation, often involving the long bones, vertebrae, and the clavicles.
Definitely a scary diagnosis. Keeping up with pediatrics, our second lesson of this issue is sticks and stones, pediatric growth plate fractures. Thank you to Drs. Bhakti Sangani, Joshua Curran, and Prayag Mehta for writing this article.
Now, Danya, we often talk about growth plate fractures, but I don't think we've ever really discussed them in detail.
You're absolutely right, Wendy. Growth plate fractures, which are also called fascial fractures, are high risk because when missed, and that might be a serious injury, it can lead to bone growth arrest. And growth plate fractures are actually quite common. They're 15 to 18% of all PEDS fractures. So they're common and can be scary.
Wow, okay. Maybe let's start with a review. What are growth plates and how do they normally develop?
So in children, immature long bones have 2 growth plates, one at each end, that contribute to longitudinal growth. The areas of a long bone include the epiphysis, physis, metaphysis, and diaphysis. And a picture is worth 1,000 words. Figure 1 in the article is fantastic. Now, growth plates are made up of cartilage produced by chondrocytes, which allow the long bone to grow and lengthen. When these cells die, the growth plates close and the cartilage is replaced by mature bone in the process of endochondral ossification.
Okay, it's coming back to me now. So how does this affect injury patterns?
Because the growth plate is composed of cartilage, it's a weak point in pediatric bone. The weakest part of the growth plate, and where most fractures occur, is the zone of provisional calcification, and it is weaker than its surrounding osseous ligamentous structure. What this means is that while the growth plate is there, when you have an injury, the growth plate is more likely to be injured than the ligaments. But after the growth plate closes, the fracture risk decreases and the injuries typically manifest as sprained ligaments. Another important thing to consider is blood supply. The blood supply to the physis is primarily from the epiphysis. When the blood supply becomes compromised in fractures that separate the epiphysis from the physis, the risk of delayed wound healing and complications increase.
Okay. Now, oftentimes we talk about pediatrics as up to 18 years of age in our clinical practice. Is that how long we need to worry about all of this?
Well, don't get me started about the fact that 18 does not make any sense to call everything peds. And especially in this case, the answer is it depends. Skeletal growth typically occurs until the age of 14 in girls and 16 in boys. The distal tibia and fibula physeal plates fuse by 12 to 16 in girls, 14 to 19 in boys. The distal radius is 18 in women and 19 in men. As you can see the pattern here, it tends to be more when you have higher levels of estrogen, because that contributes to earlier plate closure.
I see. All right, let's get into the different types of growth plate fractures.
I'm sure you all remember the Salter-Harris. At least I do. And there's a great figure in the article that summarizes it with an acronym SALTR, S-A-L-T-R. Type 1 is S, straight across. 2 is A, above. 3 is L, lower. 4 is T, through. And 5 is R, erasure of the growth plate. So type 1, which is straight across, you have the fracture through the hypertrophic zone of the growth plate, separating the epiphysis from the metaphysis. And it's diagnosed clinically by having point tenderness in the area because x-rays may appear normal. An example of that would be the SCIFI, or slipped capital femoral epiphysis, which is common in adolescents. And these fractures usually heal pretty well with immobilization. Type 2, above, is when the fracture is through the physis and metaphysis, leaving a triangular metaphyseal fragment attached to the epiphysis, called the Thurston-Holland sign. It is the most common type, and the most common areas it would be the distal radius and the ankle. It's usually treated with casting. Sometimes for distal tibial fracture, they may require surgery just because they're considered high risk. Type 3, for lower, it's an intra-articular fracture extending through the epiphysis and physis. For an example for that would be the tilo fracture in the distal tibia. And this fracture is typically caused by supination with an external rotation force or the medial rotation of the leg on a fixed foot. And sometimes it can be difficult to really look and realize what the details are like on an x-ray, and we may require a CT. These injuries require precise reduction to prevent arthritis and growth issues. So if there's any displacement more than 2 millimeters, then surgery is required. Type 4 is through, and that begins intra-articular and extends all the way through the epiphysis, physis, and metaphysis. And they're often unstable and need surgical fixation, such as the triplane fractures of the distal tibia. They happen usually in adolescence as a form of supination and external rotation. And finally, the most serious and thankfully the most rare is type 5, which is our crush injury. And that happens from axial compression and damages the growth plate. And it usually occurs in joints that move across one plane, like the knee and the ankle. And the unfortunate nature of it is that it's often diagnosed retrospectively, and it has quite poor prognosis with a risk of limb length discrepancy.
That was a great review. What would be the best imaging modality to assess for these growth plate fractures?
Well, x-rays are typically sufficient. We need to get at least 2 orthogonal views. Sometimes we also need to add the oblique and lateral views. We need to remember to image adjacent joints to prevent missed fractures, especially in our nonverbal patients. And stress views, although they talk about them a lot in ortho books, like the weight-bearing view or the valgus varus stress views, these are not recommended in the emergency department due to the risk of worsening the fractures. That's someone else's x-ray. And then remember that type 1 and type 5, so the best one and the worst one, may appear normal on x-rays. And that's why if you suspect either of them, conservative management and repeat imaging is advised. Rarely, MRIs and CTs are necessary, but that's incredibly rare, and it usually helps for preoperative planning or suspected occult fractures.
Got it. How about management?
So that depends. The patient's age, the fracture type, the location, the neurovascular status, the joint stability, the skin integrity. Obviously, if you have ortho available, please reach out to them. That might be really helpful. Make sure to manage pain, whether we're talking about NSAIDs, opioids, intranasal ketamine. And if you need to do a reduction in immobilization, procedural sedation might be necessary. For fracture reduction, displaced fractures should be reduced early to prevent complications. For type 1 and type 2 should be within 5 days, and that way they can stay non-op. However, if you have to do repeated closed reduction attempts, then just stop and refer them to ortho because open reduction is preferred, because this repeated attempt at reduction may actually worsen the injury. Type 3 and type 4 require surgical reduction no matter what timeline has passed. Just like any fracture, we need to have a good neurovascular assessment before and after immobilization. Obviously, if there's neurovascular compromise that's not improved with the immobilization, then surgical intervention is urgently necessary. Remember to discuss with your patient and their families that the risk of growth arrest is in 5 to 10% of cases, which may lead to limb length discrepancy or an angular deformity, of course, depending on which specific type on the Salter-Harris classification. And then finally, follow-up care is important to monitor healing and manage complications.
That makes a lot of sense. Tell us a little bit about specific discharge instructions for these patients.
So we need to make sure to arrange follow-up within 3 to 7 days for stable fractures. For unstable fractures, these patients are going to need to be seen a lot by their orthopedic surgeon, up to twice a week, to monitor their alignment and make sure they're healing well. And that can be up to 1 year of monitoring. For type 1 fractures, sometimes pediatricians are comfortable following this up, so they may not need to actually see a specialist. Remember to inform both the patient and the caregiver about weight-bearing restrictions, if any, and the activity limitations. And of course, return precautions and pain management at home.
Well, thank you, Danya, for taking us through this lesson. This was a great refresher on, of course, pediatric growth plate fractures that we've all learned about before, but need that refresher for sure. And definitely refer to the lesson as well as the diagrams, including the review of the Salter-Harris classification. It's an important topic because, as you mentioned, the growth plate is the weakest part of the bone for these pediatric patients, and that's why these injuries occur at that spot. And as we know, again, from the Salter-Harris classification, it certainly can be something that heals quite well with just immobilization, such as with a type 1 injury, all the way to very severe injuries, such as the type 5, where patients can even have damage of the growth plates that lead to limb length discrepancies. I think the key takeaways that I have from this is that we need to have a high index of suspicion. We want to immobilize and reduce any displaced fractures early. Although if you're having trouble getting it reduced in alignment, getting in touch with your orthopedic consultants is also helpful because some of these cases, especially the higher grade injuries, would need open reduction for fixation of those fractures. And then in terms of follow-up is super important as well. Certainly stable fractures can follow up within 3 to 7 days or so. Unstable fractures, you likely would have already gotten them involved with your orthopedic consultant. And while we may provide analgesia for these patients, we also want to make sure we give clear instructions on weight-bearing restrictions and activity limitations, and once again, educate the family on the potential for growth arrest because of these injuries of the growth plates.
Well, thank you, Wendy, for such a great summary. Our drug box this month is ceftazidime avibactam.
We've probably seen it around in our hospitals nowadays since it's a third-generation cephalosporin used for multi-drug resistant gram-negative organisms, oftentimes dealing with intra-abdominal and urinary tract infections. Now remember, if you are treating an intra-abdominal infection, you should also give it in conjunction with metronidazole. Some considerations would be for patients who have renal dysfunction, we do have to adjust our dosage. And because it is a pretty broad spectrum antibiotic, there's always that risk of C. diff colitis.
Great reminders. And then last but not least, our tox box this month is bupropion toxicity. Most commonly, this happens from oral ingestion of extended release formulation. In addition, absorption gets saturated, so the drug concentration continues to rise over 8 or more hours. Anybody who's ingested extended release bupropion of 900 milligrams or more must be admitted. Patients need to be monitored for tachycardia, QRS widening, QT prolongation, agitation, altered mental status, and delayed seizures. Seizures can be idiosyncratic or dose-dependent. In severe cases, patients may even have cardiogenic shock or CNS depression that can mimic brain death. Patients who are seizing need to be treated with benzos and or phenobarbital. For shock and QRS widening, consider bicarb, although may or may not be effective. And if a person is in a refractory cardiogenic shock, then consult for ECMO.
Scary stuff.
Indeed. Well, thank you, Wendy, for taking the time to go through this issue with me. Our dear listeners, we hope you've enjoyed listening to us as much as we've enjoyed recording this.
We hope you find the Critical Decisions publication and our podcast always informative, often enlightening, and never boring.
Reach out to us on our social media. Instagram and Threads is at Dr. Danya Khoujah.
Mine is at Dr. Wendy Chang.
And if you want to reach out to us on Blue Sky, then let us know. Then we'll get on there. And until next month.
Bye-bye.